Good evening, everyone. Can you hear me? Hello.
Yes,
Yes, ma'am.
Yeah.
Shall we start?
yes,
Ma'am.
Okay. So today's topic is kidney and ureter. So initially we'll be discussing the anatomy, relevant surgical anatomy of kidney and ureter, and then we'll talk about the renal stones today. Okay, which happens to be one of the most common clinically encountered condition. Okay, so first about the kidney. So we know that humans we have a pair of kidneys. Okay, and kidney is having an outer cortex and an inner medulla. Okay, so the outer part is the cortex, the inner part is the medulla. So the medulla, there are a number of structures like this, pyramidal structures, which are called as the renal pyramids. So we have around 10 to 12 renal pyramids. Okay. So the
Yes, ma'am.
renal pyramid is placed like this. Okay. So the base, the wider base is at the cortex and the tip is at the medulla. So the tip is called as the papilla. Okay, it's called as the papilla. Here, the collecting ducts, they all join at this point, which is called as your papilla. Now, this papilla will open into what is called as a minor calyx. Okay, it opens into what is called as a minor calyx. Okay, so two to three minor calyx will join like this to form a major calyx. So this is called as your major calyx. So each kidney has two to three major calyx. Okay, that. In the end, the major calyx will all join to form the renal pelvis and then continue as the ureter. Is that clear?
Yes, ma'am.
This is the renal pelvis, and this is the ureter. Right. So the urine, as the blood gets filtered, the urine is formed. It flows through the papilla into the minor calyx, major calyx, renal pelvis, and ureter, and further on to the bladder. Okay. So this is the initial anatomy part of the kidney. Okay. So we all know this much. And what is to be remembered is that um, each kidney, okay, here like this, is supplied by the renal artery and the vein. Okay, so we know that we have a pair of renal artery as well as the vein. Now, renal arteries, okay, will form what are called as segmental arteries. Let's talk about the branches. First, we have the renal artery. So, the renal artery is going to divide into the segmental arteries. There are five segmental arteries. You must be remembering this from your anatomy. We have five segmental arteries. Okay, so out of five, one is posterior and the rest four are anterior. Is that clear?
Yes.
Okay. So we have five segmental arteries. That is, each kidney we have the artery divided into one posterior and five anterior branches. Okay, sorry, four anterior and one posterior branch. So this four anterior branches. What are the names? One is called as the apical. Then we have the upper, middle, and lower. It just corresponds to the part of the kidney that they supply. That's it. Okay. And these arteries are called as the end arteries. Have you heard of the term end arteries?
Yes, ma'am.
Okay. End arteries meaning these arteries will supply the corresponding parenchyma and end there. There are no collaterals. As a result, if there is blockade in these arteries, it will result in the ischemia and the infarction of the corresponding renal parenchyma. That is, that part of the kidney will end up going for necrosis. Okay, that will be the dead part of the kidney. There are no collateral development. So important is they are all end arteries. Okay, now let's move on to the very most important concept that is the relations of the kidney. Again, kidney is related to a number of structures anteriorly and posteriorly. Okay. Now we need to see the structures that it is related anteriorly and posteriorly, both the kidneys. Because when you're doing surgery, when you open up, Okay, you won't be seeing kidney separately. There's so many structures you're going to see. You need to move them, you need to retract them, some you need to cut, some you need to be very careful of. That's why for a surgeon, relations are extremely important. Okay, so can we continue? Are you guys with me?
Yes, ma'am.
Now this is the right kidney. Okay, we'll talk about the left kidney in a while. Okay, now kidneys are retroperitoneal structures. Agreed?
Yes.
They're not covered by the peritoneum. Fine. Now, here above the kidney, here you know you have the renal gland. Correct? This is the right side. I'm writing here the right side. Fine. And here you have the C loop of the duodenum. That's the second part of the duodenum. Fine. And here you have the colon. Okay, this is your colon. That is nothing but your hepatic flexure. Correct? This is your hepatic flexure.
Okay.
Hepatic flexure. And you're going to see all this. Okay, see, whatever I drew now will be seen only after you elevate the liver. Let's say you cut the abdomen. Okay, you remember your dissection from anatomy. You have put a midline incision. You have opened this abdomen, and you put the liver on top. Correct? So
Yes.
you crack the liver, and underneath you're going to see all this. Is my point clear? So
Yes.
now you need to tell me what is this area covered by? What is present above this area? What is present above this area? If we have to retract the liver to see the underlying structures, so this structure is covered by the liver, no?
Yes.
Does that make sense?
Yes.
So these form the anterior relations of the kidney. Okay, shall we name them? One, the
Right.
right adrenal gland. Two is the second part of the duodenum. Okay. Three is the hepatic flexure. Four is the liver. Is that understood?
Yes, ma'am.
Should I go slow or is this fine?
Hi.
Okay. Now we'll go on to the left kidney. Okay. Now with the left kidney, something similar to this will happen. Here you have the left adrenal gland. Okay. Then here you have the spleen. So we know spleen is on the left side.
Yes.
Okay. Here you have the spleen, and this here is your pancreas. Okay. This part is your pancreas. So you should know that there is C loop of duodenum, which is here. Okay, basically, this whole picture should be here, moved close. Okay, I've given a separate picture so that you understand it more clearly. Okay, this is your pancreas, and here you have your colon again. This will be your splenic flexure. This is clear? This is
Yes.
nothing but your transverse colon. This will be your descending colon. This is your splenic flexure. And this area over here will be covered by your what? Stomach. This is on the left side, na?
Yes.
So there is stomach on this side. So these form the anterior relations of the left kidney. Can we name them from the beginning? One,
Yes, ma'am.
one
I
is
don't know.
very good. Two,
Spleen.
spleen, very good. Okay. Then three is
Pancreas.
Pancreas.
the tail of pancreas or the body of the pancreas?
Body of the pancreas.
Body.
Tail.
Body.
Very good, very good. Body. Not be tail because the tail will go into the hilum of the spleen.
Yes, ma'am.
So the right answer will be the body of the pancreas. Then coming to the fourth one, which is
Spleen.
flexure. This blue part here is the fifth one.
Stomach.
Stomach. Very good. So these form the anterior relation of the right as well as the left kidney. Now, are both the kidneys at the same level anatomically?
No, ma'am.
All right. So the right kidney is at higher level or lower level?
Lower level.
Lower. Why so? It's because
Hepatic.
very
Liver.
good.
Right. Due to
So the liver will
liver.
let the further upward migration of the right kidney. Okay, because the liver is big, it will occupy the area. So right kidney is at a lower level. Fine. Now you can say the hilum of both the kidneys, okay, will almost lie at the level of L2, right? That corresponds to what is called as the transpyloric line. So when you're doing the surface anatomy, okay, when you put these grids on the abdomen, there is a line which is called as the transpyloric line passing at the level of L2 that will correspond to the location of the hilum of the kidney. Okay,
Yes, ma'am.
fine. So let me fine. So now this forms the anterior relation. So I said that okay, if we go back to this, if you see here, there is liver now and there is kidney. So there is a location which is called as the Morrison's pouch. Have you heard of Morrison's pouch?
Yes, ma'am.
What is this Morrison's pouch? It's nothing but the hepatorenal pouch.
Yes, ma'am.
The hepatorenal pouch or the space. Now see, the liver is covered by the peritoneum. So the posterior part of the liver, which is having the peritoneum, and the anterior part of the kidney, there is a space. Correct. That pouch, that space is called as the hepatorenal pouch. Are you getting it?
Yes, ma'am.
Right. So the anterior relation is liver now in front of the kidney. So the space between that liver and the kidney, there is some space now behind it. So that
Yes,
is
ma'am.
the Morrison's pouch, and this happens to be the most dependent part when the patient is lying, when the person is lying down. Correct. So, if you've done any abdominal surgeries or anything, if there is any collection in the peritoneal cavity, it is more likely to be in this space when the patient is lying supine. You get it? So, this will be the most dependent part. Okay, in supine position. Why is this important? If you've done any surgery, it becomes important and mandatory to put a drain in this position. You
Is there
keep a
any
drain.
collection?
Sorry?
Is there any collection in
Exactly. So if after surgery, if you have any collection, if you leave it there, what will happen? It will get infected and there will be peritonitis. So you have
yeah.
to drain it if there's any collection. So you put a drain in this place and you leave it for a few days following the surgery. Okay, that's one thing I had to tell there. And okay. Hmm. Here. So now we talk about the posterior relation, anterior relation. We'll talk about the posterior relations now. So posteriorly, again, we have our right kidney here. Okay, this will be our left and this will be our right because we're seeing it from the back. Does this make sense?
Yes, ma'am.
Okay, right and left. Okay, first we have a rib. So right is at a lower level, as I told. So 11th, sorry, on the left side you will have the 11th rib and the 12th rib both. On the right side you will have only the 12th rib. Clear? 12th rib, your 11th and the 12th rib because this is at a higher level compared to the right side. Okay. Then we have muscle over here. Okay, here you have the most medial part is your psoas major. The kidney will lie on your psoas major muscle. And this is your psoas major, the one in the red. Now let's mark 2 to 3 nerves here. We have the subcostal nerve, the iliohypogastric nerve, and the ilioinguinal nerve on both the sides. The posterior relations are very simple. We have two ribs on the left side, right side we have a single rib, three nerves. So, should I write it down? The first one is the subcostal nerve. Next we have the
You have
hypogastric nerve. Then we have the inguinal nerve. Okay, you must remember this. I'll tell the importance of this when we talk about the uretric stones. Okay, uretric calculi. Okay, we're talking about the referred pain over there. I'll tell about these nerves. Then this, what is this muscle?
Swas.
Psoas major.
Major.
Yes. Psoas major. Fine. So these form the most important posterior relations. Now we have finished the kidney for once. We will go on to the ureter. So ureter, what is the length of the ureter?
25 centimeters.
Very good. 25 centimeters, out of which 12.5 is abdominal, and the neck rest 12.5 centimeters is pelvic. Okay. When can you say it is abdominal pelvic? When it crosses what is called as the pelvic brim.
Yes, ma'am.
Okay. When it crosses the pelvic brim, it becomes pelvic. Now, what will be the diameter of the ureter? It is as thin or as small as 4 mm. Yeah, that's why you see any obstruction. Small calculi will also cause obstruction and pain because the inner diameter is only 4 mm. And at the same side, if you have to put a scope through the ureter, what should be the size of your scope? Less than 4 mm. Correct?
Yes, ma'am.
Be somewhere around 3 mm. That will be the size of your scope. That's tiny the scope will be. And the tinier it gets, it becomes very, what do you call, pointed.
Yes, ma'am.
So the most common complication that it will result in will be perforation. You have to be very gentle when you're going to put this scope into the ureter. It's called a ureteroscope. When you want to pass it, you have to be very careful. Otherwise, if you just thrust it like that, it will cause perforation.
Perforation.
Okay, fine. So now we will talk about the relations of the ureter. Nothing much. They're very two to three very simple relations that you need to know, and the constrictions of the ureter. Okay, so uh, this is your right kidney, this is your left kidney, you have the pelvis, and then here you have the ureter going down. Okay, whatever I say on the right side will be same similar thing on the left side, not all not the same exactly. Okay, so I told you this is the renal pelvis, correct, and this is your ureter. So this junction is called as the
Pelvic.
pelvic junction. PUJ. It is the first anatomical constriction that is present in the ureter. Next, it is going to pass through what is this? This is your pelvic brim. Let's say this is your pelvic brim. Okay, so this will be your second constriction when it is going to pass in the pelvic brim. So when it is going down, okay, what happens is here you have your artery. Which artery is coming here? See, this is your abdominal aorta, correct? The renal
Yes.
artery is coming, big arteries over here. Then as it comes down here, it is going to divide into what are these? The common iliac vessels.
Yes.
Correct. The common iliac will then give the internal iliac and the external iliac, internal and the external. So the second constriction is when the ureter is lying over the common iliac vessel when it is going to enter the pelvic brim. Correct. So see, I have written the ureters first. Actually, first there is an artery, and the ureter will be above it. Okay, that is your second constriction, right? And next in males, what happens? It is crossed anteriorly by the vas deferens. What is vas deferens? This spermatic, the
Diabetic.
continuation of it. Yeah.
Continuous.
Yes. So this will be your third constriction. Okay, when the ureter is crossed anteriorly by the vas deferens. So logically, this will be seen only in the males.
Male.
Okay, fine. So next, what happens is that it is going to enter the bladder. This is a bladder. So here you have the intramural part of the ureter. Correct? It is going to enter. This is called a vesico-ureteric junction. Vesico-ureteric junction. So, which is the narrowest part now? The vesico-ureteric junction is the narrowest part. Narrowest part of the ureter. Okay, is that clear? And when the ureter is coming down, what happens is that anteriorly it is crossed by a gonadal vessel. So this is your gonadal vessel passing like this. So what are these? The right and the left gonadal vessels. They're going to cross from medial to lateral, anteriorly. Is this relation clear?
Yes, ma'am.
Okay. That's about the ureter. And what kind of epithelium? What is the lining of the ureter? It is lined
Trans-
by transition epithelium or transitional epithelium, which is the same as that of the
Bladder.
very good. So the lining epithelium is the same. Next, if you have to see about the blood supply. Okay, blood supply of the ureter is pretty important. The ureters are supplied by the following arteries. In the again, we'll draw one kidney in the ureter. Okay. The upper one third is supplied by your renal artery only. Okay, the upper one third. Then we're talking about the middle one third, where you have what I told you, one artery crosses it anteriorly from medial to lateral. What is that?
Gonad.
Yes. So the middle one third is supplied by your gonadal artery, branches from the
Abdominal artery.
gonadal artery. Then the lower part, the lower one third, here you have what is called as the superior vesicular artery. Superior vesicular artery is nothing but the artery which is supplying your vesicle, which is nothing but your bladder. Okay, superior vesicular artery. And it is supplied by a number of tiny branches from so many other arteries. Okay, like for example, inferior vesicular artery, the uterine artery in females, vaginal artery, middle colic arteries, middle rectal artery. So these are all the branches of what is called the internal iliac vessel. I told you the common iliac is going to give internal iliac and the external iliac. So
Yes,
whatever
ma'am.
branches I mentioned, a number of branches which I just mentioned are all branches of the internal iliac. Now, if you're given an MCQ that the ureter is supplied by the following except, okay, your answer should be external iliac artery. Because none of the branches of the external iliac are going to supply the ureter. Okay?
Yes, ma'am.
So now we will go on to the renal calculi. So these are the important parts that I have to mention. Now regarding the renal calculi or nothing but the renal stones. So this is very, very common. Okay. You might
Yes,
have
ma'am.
seen one or two people or like whom you know might be suffering from renal stones. So there is a term that I want to mention here, that is the Randall's plaques. Have you heard about this term?
Yes, ma'am. Soft tissue calcification.
Yes. So these are nothing but your soft
Soft tissue
tissue
calcification.
calcification. Where is this present?
Renal medulla.
Yes, this is present in the medulla. Now, this is going to act as a nucleus because there's already some amount of calcification. It's going to act as a nucleus around which further deposition of the infection, stones, and bacteria will lead to stone formation. So, this is one of the predisposing factors for development of stones, renal stones. Okay. Now, if the renal stone should occur, there are two important processes that should happen. One is called as the supersaturation sorry, supersaturation. The next one is crystallization. So when can supersaturation occur? When you have a lot of solutes, increased solutes or decreased water content in the urine. Correct? So the causes for increased solutes could be many, which we will enumerate in a while. And decreased water intake, okay, dehydration could be the causes for supersaturation. Once there is supersaturation, it will lead to crystallization of the solutes and there will be formation of stones. Okay. Now we'll talk about the different types of stones. So the most common we'll talk about the types of stones. Right. So the most
calcium
common
oxide.
one will be your calcium stones. Correct? Your calcium oxalates. Oxalates are the most common stones. Okay, calcium stones. Now, what could be the causes for calcium stones? One is you're having increased
Hy-
calcium in the urine. Okay, it could be because of a number of reasons. Let's talk about it. One is called as the absorptive hypercalciuria. Just write down the terms. I'll explain what this is. Then you have reabsorptive hypercalciuria. Then another term which is the renal hypercalciuria. So in all these conditions, we have hypercalciuria, that is increased calcium in the urine from stone. Now, what do you mean by absorptive hypercalciuria? Meaning your gut, for some unknown reason, are absorbing more calcium from the gut. Calcium absorption is more. You've taken more vitamin D, you've taken more calcium in your diet. So there is increased calcium from the gut, coming from the gut. Next is the reabsorptive. From where are you reabsorbing, putting into the blood and hence coming in the urine? It is from the bone. What is a condition where you will remove more calcium from the bone? What is the condition?
Resorption.
You're producing reabsorption of calcium from the bone. The bones are becoming weaker and weaker.
Resorption.
Yes. So, what is that condition? It's a endocrinal condition.
Osteoporosis.
Osteoporosis is age related. What is the endocrine condition? Which hormone is associated with calcium metabolism?
Parathyroid.
Parathyroid.
Hormone.
Exactly. So increased parathormone. So when there's increased parathormone, it's going to cause more of resorption of the bone. So increased calcium in the blood. So again, increased calcium in the urine, causing reabsorptive hypercalciuria. Next is renal hypercalciuria. Here the kidney is not absorbing, okay, not absorbing the calcium. So it is just getting excreted in the urine. Correct? These are the causes. Now for oxalates, there's a condition called hyperoxaluria as well. Hyperoxaluria. So one, it could be because you took more oxalates in your diet. Best source of oxalates would be something you take every
Tomato.
day in the morning.
Tomato.
Tomato.
Sorry, green leafy
Tomato.
vegetables they all have, but then see, phytates and oxalates are more in tea, tannins and all. So tea is a rich source of oxalates. Okay. So then coming to another bowel condition, okay, wherein you have let's say small bowel condition. We have resected some amount of the bowel, and now it's gone in for malabsorption. Okay. Here, what happens is that the lining epithelium will be there, na, of the gut will become more permeable for oxalates. It happens in malabsorptive syndromes like that of, let's say, Crohn's. Okay, like Crohn's disease. So here, the permeability of the intestine is more for oxalates. Okay. So these are the conditions for hyperoxaluria. Fine. So we are going to have calcium oxalate stones. Now, calcium stones are what do you call? They radio opaque or radiolucent?
OPEC.
Radio opaque.
Opaque.
Very good. So we are going to study a number of other stones. While we study that, I'll tell you whether they are radio opaque or radiolucent. Okay. Now we'll go on to the next variety. Or I just mentioned here about the monophasic. Okay, we have two types in this. Okay, calcium oxalate stones could be monohydrate or dihydrate. Monohydrate and dihydrate. So the monohydrate stones if you see under the microscope, okay, you got a crystal and you put it under a microscope. How does this look? This looks like a dumbbell shaped. Okay, so the monohydrate stones are dumbbell shaped. The dihydrate stones look like envelopes. So these are called as the envelope shaped or the bipyramidal shaped crystals. Should I write that down? Monohydrate are dumbbell shaped. Okay, so dihydrate are nothing but envelope shaped or bipyramidal shaped. They'll inevitably ask these shapes in your entrance exam. So they'll give a number of options for this. So you'll have to remember the appearance. Okay. Now next let's move on to uric acid stones. Okay, uric acid. So uric acid stone, again logically, there is increased production of uric acid. What could be the reasons? What are the two main conditions where you see increased uric acid in the blood?
Gout.
Very good.
Gout.
And one metabolic disorder. There is a
Metabolism.
metabolic disorder where you will have self-destructive habits with mental retardation. It's a condition that you've studied in your biochemistry in first year. It's a syndrome with self,
Leishman syndrome.
yes, with self-mutilating features that is called Leishman syndrome. Very good. Okay. Then you could also have it in case of myeloproliferative.
Proliferative.
Yes. What happens in myeloproliferative disorders? You're producing
Cell
lots of
bed.
cells. Yes, it's nothing but your leukemias. Yeah, you're producing a lot of cells. In the end, all of them will die. Na? So there will be, once there is destruction, you'll have lots of purine and pyrimidines coming in. So uric acid is basically because of increased purine metabolism. Yeah. So if you see the ultimate pathway of the purine metabolism will be from hypoxanthine, there will be something called as xanthine.
Yes, sir.
It will ultimately
Something called
become your uric acid. Correct? Yes. So you just mentioned a drug. What is that drug name?
allopurinol.
Allopurinol. What does allopurinol do? It's going to block
It
the.
blocks the pathway hypoxanthine.
So you will not have any uric acid. So you don't have uric acid, you will not have the stone formation. So uric acid stones will not be formed. Now, apart from this, okay, you can give allopurinol. What will be the other ways of managing this condition? First is, I said it is because of supersaturation, which can occur because of increased uric acid and decreased water. So what will you advise them?
Drink plenty of water.
Exactly. So the first advice that you would give to any renal stone patient. Okay. And uric acid, as it is in the name, it is an acid. So see, if you give them a base, what will happen? Acid plus base is going to form a
Salt.
salt. Salt is going to be water soluble.
Yes, ma'am.
Another logic in the management of renal stones would be if it is a basic stone, give an acid. If it's an acidic stone, give a base. Basically, form salt and precipitate that. That means it will form salt which is soluble in water and goes away. So now if it is an acid, what should you give? You should give a base. You should alkalinize the urine. The agent that we use is acetazolamide. So acetazolamide is an alkaline agent that's going to form salt. Okay.
Yes.
Then one more thing is diet. You just ask them to take less purine in their diet. That means avoid animal products, meat and the basically the red meat. All these
Yes.
products should be avoided. That would be the management part. Then, is uric acid radio opaque or radiolucent?
Radiolucent.
Translucent.
Lucent. Now, there's a mnemonic that I want to give here. It is called the IT University of Xanthine. Somehow I just like to remember it like this: IT University of Xanthine. The U is for
Uric acid.
Uric.
acid. Xanthine, as you can see here already, it is also radiolucent. You can get to know from here. And IT. T stands for triampterine, and I stands for indinavir. Does these things strike any chord in your brain? Do you remember what these things are? What are these? Have you heard
And
of these names?
Indidapir, that is the anti-HIV drugs,
Yes,
antiviral.
it's antiviral protease inhibitor. It's one of
Yes.
the protease inhibitor. Okay, then triampterine.
Potassium sparing diuretics.
Yes, this is a potassium sparing diuretic that we use. So, overuse of these drugs can cause stones, and these stones will happen to be radio leucine.
Lucent.
This is the mnemonic. And I told you one more logic, na? The acidification and alkalinization. The
Yes.
mnemonic for that is CCU. These are all drugs which are acidic in nature. U for again, you know,
Uric.
Uric acid.
uric acid. C is basically your calcium stones. And another C will be your cysteine. We'll study about
16.
the cysteine. Okay, so these are all acidic components. Okay. Now, the uric acid, as I told, it is radioleucine. How does this stone appear? It's going to have, it's like a rosette shaped. Yeah, rosette shape. So it's going to have multifaceted structure. As in, it's just so irregular. It's like you take some structure and you have multiple surfaces on it. You just cut it like that. So it will be rosette shaped and multifaceted. There's no one strict structure for it. Okay, that's about your uric acid stones. Now let's next move on to another important category. Is nothing but your struvite stones. Struvite, also called
Stagon. Plus.
dragon
Triple phosphate.
phosphate or stagon. Okay. So what are the triple phosphate? What are the three components here?
Calcium, magnesium.
Yes,
Phosphate.
Calcium, magnesium.
and ammonium. Very important.
Yes.
NH4 and phosphate. So triple stands for calcium, magnesium, and ammonium. Now, see, this is common in males or females?
Female.
Females.
Yes. So, see, renal stones are more common in males in general, but screw white stones are more common in females. Okay. See, these stones are infective in etiology. Okay.
Yes.
They're because
Yes.
of infections. Now, UTIs are more common in males or females.
Female.
Females.
Female.
Reason is
Short urethra.
Short urethra.
urethra is just around 4 centimeters.
2 centimeters.
Right? More commonly they'll have infections. Now, if there is an infective nidus, the result in formation of stool stone. Now, infection is with an organism called as the proteus.
Protease.
Okay. Now, this proteus will produce an enzyme. What is the name of the enzyme? It is
Ma'am?
urease. So, proteus is the organism which is going to produce an enzyme called as urease. What this urease does is it is going to break down your uric acid into
Urea. Ammonia.
ammonia. Okay. Now this ammonia is an H3. So it will be added, it will get one H added with it and becomes an ammonium ion. And this ammonium is nothing but this ammonium that you're seeing, triple phosphate. Okay. So next time you don't need to remember so much. This ammonium is there, you know triple component is ammonium. How is ammonium coming? It's from protease because of the presence of
Yes.
the enzyme urease. Right?
Yes.
Now, these stones are usually very large. Okay.
Mm.
So unlike the others, these are very large. Now, they are going to occupy the whole of your calyceal system. Okay. So, the whole stone will be occupying this space here. So, it is going to look like a horn of a stag. So, that's why it's called as staghorn calculus. That's why this name. Okay.
Yes, sir.
Now, these stones, they are going to let's say, occlude the whole of your draining system. Okay, so hence it's going to cause backpressure onto the kidney. So it will cause silently, it will cause damage to the kidney. Okay, it causes silent damage to the kidney. Now these are two big. You cannot use one modality for removal of the stones. You will have to use multiple modalities. Okay, I'll
Yes,
just
ma'am.
talk about it. You just write it down. It's called PCNL with ESW. Okay, we'll see what are these procedures in a while. Okay. Now, let's say a patient is repeatedly having screw white stones. Repeatedly. That means bar she is having infection with protein. Now, in that case, you can give a drug which can inhibit the urease. The drug is
Yes, yes.
acetylcholine.
Hydroxamic acid.
Yes, hydroxamic, sorry, acetoxy, hydroxamic acid. I'll try to remember it as triple A drug. So these are used to inhibit the urease enzyme. Okay. Next, we'll have a look at the cystine stones. So this happens due to a condition called as the cystinuria, again a metabolic condition where we have excretion of cystine in the urine, and these stones happen to be the hardest stones. So very hard. You cannot break them. Okay. So what do you do here? They're the hardest because of the presence of the disulfide bond. Okay. Cysteine is having sulfur containing amino acid, na? So it has sulfur in it. So this will form disulfide bonds. And they assume what is called as the benzene or the hexagonal structure. So this structure is very difficult to break. That's why they form the strongest bonds. Correct?
Yes, ma'am.
Fine. So next, a little word about the xanthine stones. We already know. There's a specialty of xanthine stone. Not the mnemonic.
And
University of xanthine. So that is one of the
radiologist.
radiolucent stones. And again, it is can be inhibited by the drug aloe.
Urinal.
Correct? Fine. Now, on microscopy, you see them as brick red uh, crystals. Okay, the brick red is one of the features of xanthine stones. Now, if the patient has renal calculi, how will they present to you? The first thing they're going to have is pain.
Yes, ma'am.
Talking about the
Have
clinic.
the
Yes, you're in the emergency, you're in the casualty room, and most commonly these are the patients who come in the early morning, around 4 to 6. So those most of those patients who come during that time will be having renal calculi. So they come with pain, abdomen, and this happens to be more in the month of Ramzan. You'll know why, because they'll be fasting. They'll not take water throughout the day. And dehydration, lack of water, is another predisposing factor for stone formation. This is one of the
yes, ma'am.
seasonal variation we see in this disease. Okay. So pain abdomen. They'll have pain in the flank region. Okay. Usually they will say it is radiating to the nose. It's classically described as loin to groin.
Loin to ground. Yes, ma'am.
Correct? This is your
Yes.
clinical term that we use, loin to. Now, as I have mentioned, the nerve supply of the ureter, I mean the kidney, the relation of the nerve to the kidney, we'll talk about the radiation. If the stone happens to be in the upper third of the ureter, middle third of the ureter, and the lower third of the ureter. First of all, they'll have pain on the flank region, correct, corresponding to the kidney. Now, what happens is pain here, it will radiate to the, let's say, the testis in male and the labia majora in females. Okay, you could remember it because there is the gonadal nerve also passing over there. Okay, it could be because of that. If it is in the upper third. If it's in the middle third, it will be radiated to the hypogastrium Okay, and your what is this? Iliac fossa. If it's on the right side, it will be related to the right iliac fossa. On the left side, it will be to the left iliac fossa. So, what do you think is the nerve involved here?
Iliohypogastric.
That's it. Iliohypogastric. Simple. Now, this is very important because these are the conditions that will mistake with the other acute abdominal conditions. If it's in the right side, if it's radiating to the right iliac fossa, then you will think of most common differential will be your
Right renal stone. Right
appendicitis.
appendicitis.
Very important. So, when you're in the casualty, you need to make a decision whether this is appendicitis or renal calculi. Appendicitis, you'll have to open up and do an appendicectomy. For renal calculi, all you have to do is send him home with drugs. That's all. Correct. So
Yes.
we'll take up appendicitis in a further later class. So today we are just seeing the differential diagnosis. Okay, but on the left side it will be a diverticulitis. Diverticulitis are common on the left side. So differential that we'll keep in mind will be diverticulitis. Now, if you're talking about the lower one side, the pain will radiate to the your inguinal region and the inner aspect of thigh. Inner aspect of thigh. So the nerve involved here will be
Ilioinguinal.
inguinal. So now next time the patient comes to the emergency, you will approximately get to know the location of the calculi depending upon the radiation of the pain. Fine.
Yes, ma'am.
Okay. So now they have come to the emergency. Have to order some investigations for them. What will you do? So came with complaints of pain abdomen. Okay. What could be the reason for this pain abdomen? See, this is the kidney and this is your ureter. If there's a stone here, there will be
Obstruction.
there
Obstruction.
will be ureteric colic. Because of this obstruction, what will happen? That there are smooth muscles in the wall of the ureter. So they'll try to push it. There'll be forceful contraction that will be coming over here. So it is going to cause colicky type of pain. That could be the cause. Or because of the stone, there's already enough back pressure over here. The kidney is enlarged. Okay. And the renal capsule is stretched. There is stretching of the capsule. There are two reasons for pain abdomen. One is the colic, two is the stretching of the capsule. Is that clear? Now, next we have to order the investigation. We're going to order the urine tests first. We're going to say get one urine routine and get microscopy done. So in this, you'll get to know what is the specific gravity, what is the pH of the urine, and all those things, sugar content, albumin, and so on. So then, what are we interested in? Is they'll also tell you the presence of RBCs or WBCs or pus cells. If there any presence of pus cells, then you know it is UTI.
Infection.
Yes. So you'll have to treat UTI. Just out of interest, I'm asking UTI. What will be the drug of choice for UTI? Just someone asks your relative as having burning condition. You'll have to suggest them
Cephalosporin.
which one?
Cephalosporin.
Cephalosporin is not something that we use for UTIs actually.
Nitrocyanide.
We usually give Ciplox. Okay, so this is nothing but they target your gram negative. See, the most common cause for UTI will be your either E. coli
Escherichia
or
coli.
hmm. So these are the gram negative organisms. So you'll have to give Ciplox. Usually tablet Ciplox 500 mg. We say BD for 5 days. Okay, or there's another drug which is very good. It is tablet nitrofurantoin.
Hello.
You would have learned this in your pharmacology. Nitrofurantoin 100 mg BD. Now we also give one syrup. Have you heard of that syrup?
Alka-Seltz.
Yeah. or citralca, whatever we call it. What does this actually do? See, it is citralca. Usually, it is going to alkalinize the urine. Okay, so you have the citrate content. So citrate and magnesium are the ones which inhibit the formation of stone. So they decrease the incidence of stone. So we have heard so many conditions which precipitate the stone formation. Now, there's increased calcium, increased uric oxidate, uric acid, all these things. But your magnesium and your citrate are going to inhibit the stone formation. Okay, that's why that we give citrate. Is that
Ma'am,
fine?
drug of choice of UTI is the ciprox.
Ciplox. We
Okay.
can also give nitrofurantoin. That's also a very good drug because and the only what happens with nitrofurantoin is that the only mode of excretion of that drug is through the kidneys. So its action will come in when the drug is being excreted. It doesn't undergo any kind of metabolism.
Ma'am, in case of pregnancy, so we can't give nitrofluorouracil.
You could actually there we give Ciplox only. Now Ciplox is considered safer than nitrofurantoin. Nitrofurantoin has certain side effects, so
Yes.
hence we give Ciplox.
Okay.
So drug of choice happens to be Ciplox. Then apart from the urine routine microscopy, in microscopy they'll also give you the crystals. If there are any crystals, they'll tell you what is the structure of the crystal. Now we know if it's dumbbell shape what it is. What it is? Dumbbell shape, calcium oxalate, monohydrate.
Yes, ma'am.
Okay, dihydrate will be envelope shape. So you keep revising these things. Okay, so based on the crystal ka shape, also we can diagnose the kind of stone. Okay, and we can also go for what is called culture and sensitivity, urine culture and sensitivity. This will is to rule out any presence of any infection. So they'll say which organ is this and what is it is sensitivity. Okay, all these things. Imaging studies will do what is called as the X-ray KUV. So what are the stones which are radio opaque? Everything else other than IT, UX.
You.
Correct? So they are all radio
Right.
opaque. So now for them you will do X-ray KUV and they will show up. And 90% of the the uric or the renal calculi are radio opaque.
Opaque.
90% are. Okay. And now, if you do X-ray, can you find out the condition of the kidney? If there is the hydronephrosis, can you make that out? That's not possible. Correct. You will
No,
see
ma'am.
only stone. No? You will not get to know the kidney status. So for that, you will have to do what is called an ultrasound. We will do ultrasound to find out the hydronephrosis component. And we have certain special scans that we do for kidney. Okay, that I would like to mention here. That is IVP and RGP. Have you heard of IVP?
Yes, ma'am.
That is
Intravenous.
intravenous pyelogram.
Pyelogram.
So what you do is IV. You put an IV line and you give the contrast intravenously, and that contrast will be what do you call excreted by the kidney. It's going to concentrate in the kidney, and as the contrast gets eliminated in the kidney, you're going to take serial images. One is at 0 seconds, then you will take it at 1 minute, then 5 minutes. It's like that. Okay. So take serial images. If there is a block, there is no flow of contrast, you know there is an obstruction. Correct? So here you are going to get to know the renal function also, whether the renals are producing the urine or not. Correct? And you'll also get to know the proximal part of the obstruction. You get my point? This is the
Yes, ma'am.
kidney. Okay, let's say there's a stone over here. Now, from the IV system, okay, the kidney has filtered all of that, and then this is all glowing. This is all the contrast part. It comes, and here is there's stoppage. The contrast will not go further down. It is telling that the contrast is coming here. That means the renal function is fine. Okay, and it is telling about the proximal part of the obstruction. It's going to tell us where exactly the obstruction is. That is the role of IVP. And then another investigation which is called RGP, which is nothing but your retrograde pyelogram. Retrograde
Pyelogram.
pyelogram. So here you do the same thing, but in the opposite direction. You're going to put the contrast into the bladder. Okay, you're going to like kind of flush it. Okay, and then it is going up in the ureter. If there's a block, it doesn't ascend up. So it's a retrograde pyelogram. So you will study the part which is distal to the obstruction. Does that make sense?
Yes, ma'am.
Okay. Then we will see there are two more additional special scans that have been mentioned. You must have heard there's something called a DMSA scan, the DTPA scan,
Yes, ma'am.
MAG3 scan. So I'm just mentioning here because we are running out of time for this class. This is part one. We'll continue it in the part two. So I'll just mention what these are. Okay. DMSA stands for dimercato,
Succinic acid.
yes, succinic acid scan. Fine. DTPA stands for
Diethyl
diethyl
triamine pentaacetic acid.
triamine pentaacetic acid, and MAG3 will be
Mercaptoacetylglycine.
acetylglycine.
Glycine.
Fine. So now these are the full forms that we have to know. There's no other way out. And what is important is why do we use DMSA? The answer is in the molecule. So it's S for you're going to study the structure.
Renal
Yes,
structure.
you're going to basically study about the structure of the this one, now the kidney. Basically, it's for the morphology, and it is also to know the presence of scars. So that is what you're going. This is more like a anatomical scan, if you have to call it anatomical scan. Now, if you talk about DTPA, this is more to do with the function. P for perfusion.
It's 7 o'clock.
Okay. P for perfusion means how much of blood is coming and how much of urine is being produced. So it is more of a physiologic or a functional scan. Does
Yes,
it
ma'am.
make sense? So DMSA is more anatomical. DTPA is more functional. And this MAC3 is also used to know about the perfusion. This is also similar to DTPA, but MAC3 is much better than DTPA. Is that fine? And today we'll end with the what you call management, okay, of the renal stone. There's a lot in the management, so I'll just tell about the conservative management, as in what are the patients for whom you can just say water, give citralca, give antibiotic, and so on. Who are those patients? Okay, whom you can do this. So first is the stone size. Does it depend on the size? Obviously, bigger the stone, you have to go for more surgical procedures. Lesser the size of the stone, you can go for a conservative management. Okay. So first is size less than 5 mm. All you're going to tell them is reassure. Okay. Two is if it is present in the lower third of the ureter. First is the size and then is the location. Then, if there is no dilation of the ureter, the proximal part, no dilation of the ureter, as in there are no obstructive features, it's fine, it will pass on. Okay. So, what will you tell them?
Plenty of water.
Yes, you're going to say a lot of water intake. Then, if it's acid stone, normally they happen to be calcium stones. Like most of them are calcium stones. So, you will have to alkalinize the urine. What will you give them? So, we're going to give
Acetazolamide.
syrup. Yes, you're going to ask them to take this. That's all. And then you'll be like, it will pass on. Usually, they say you should take up to 4 to 6 liters of water per day. Okay. So then further on, there's so many procedures about ESWL, PCNL, and all those things, which we'll be discussing in the next class. Okay. Now I'm just going to show you one of the slides. Can you see it now? Can you see the screen?
Yes, ma'am.
Okay. See, this is the anatomy of the kidney, which we have just seen. The outer cortex, then we have the medulla, we have the pyramids. Can you relate to whatever I drew?
Yes, ma'am.
Okay, the calyces. And one thing that is there in the picture and I did not mention is, see, the structure at the hilum from anterior to posterior. Which is the structure which is coming first? If you
Ba-
see,
uh,
the vein. See, the vein is present anterior to the renal artery.
yes, ma'am.
Correct. So the structures at the hilum from anterior to posterior would be the vein, then the artery, and then comes the renal pelvis. Is that clear?
Yep, sir.
Okay. So the mnemonic will be VAU,
Yep.
vein, artery, and then the ureter.
Pelvis.
Yes, the renal pelvis or the VAP or VAU. So whichever mnemonic is easier. Fine. Next, here is depicting the anterior relation to the kidney. I suggest you revise this again because this is volatile. But if you remember this anatomy, okay, you draw it for yourself and keep it. See, you can see on the right kidney, if you're dealing with the right kidney first, is the suprarenal area. Then I have told there is the duodenal area. It's the second part of the duodenum, C loop. Okay, then you have the hepatic flexure and the hepatic area.
Yes, ma'am.
Okay, coming to the left side, we have one extra relation to be learned. That's the suprarenal area. Then we have the splenic, the gastric, the pancreatic, and the colonic. You must be able to answer this by closing your eyes. Okay, and if you see here the structure of the hilum, it is vein, artery, renal pelvis, clearly mentioned. Okay, that relation
Yes,
is
ma'am.
very important. And if you see here, which vein is longer, the right or the left?
Left.
The left is longer. The left renal vein is around 3 times longer compared to the right. The right will be around 4 centimeters, 3 to 4 centimeters in length, but on the left side, it's going to be up to 8 to 10 centimeters. So, what is the application of this? Any idea? When will you think of a longer vein? When you have to transplant the kidney. If you're taking kidney from a person, from a, let's say a cadaver, okay, and you have to transplant it to a living person, okay, you will usually prefer the left kidney because it's having a longer renal vein. So you get lot of this one for anastomosis. Even if some part of it goes wrong, you can just cut it and suture it again. Do you get the application of it?
Yes, ma'am.
Usually the left renal kidney is chosen for transplantation. Next, this is a picture for the relations of the ureter. As you can see, it is coming down. It is lying on the psoas major. Okay, the big muscle bulbs at the posterior side are the psoas major. Then you can see the aorta bifurcating into your common iliacs, correct? And then your ureter is passing anterior to that, then coming down to enter the bladder. Okay. Next, here, renal calculi associated with proteus infection. What is it? Uric acid, triple phosphate, calcium oxalate, or xanthan?
Triple
Ma'am.
phosphate.
Full phosphate.
Yes, nothing but your agar or the true white stones,
Tag-
which are associated with your infection. It is with proteus and urease formation, all that. Okay, triad of renal colic, swelling in the loin, which disappears after passing urine. Have you heard of this thing?
Yes, ma'am. Dates. Littles.
Dates.
Dates. Staggered.
Detailed triad. What detailed triad is? There's a particular stone, let's say, it is obstructing the ureter, okay, which is causing renal colic because the ureter is trying to expel the stone. You're going to have the colicky pain, and there is stagnation of the urine. Okay, there is let's say swelling in the kidney, so that's why you're going to have a swelling in the loin region. And after some time, the patient is going to pass large volumes of urine, and the swelling will also disappear, and the pain will also disappear. That is nothing but your tittle strand. We'll see about the other threads as we go on to the further chapters. Charcoats is associated with your
Pain, fever, jaundice.
yes, senin,
Um, cholecyst,
CBD.
cholangitis, acute
Yes,
cholangitis.
yes, it is nothing but acute cholangitis in CBD stones. Okay. Then Saints triad again, we'll talk about it, diverticulosis and all that things. Okay. The right answer here is dative triad.
Little triad.
Okay, treatment of choice for ureteric colic. If we have to give one drug to manage the pain, what would that drug be? Nitrates, pethidine, PCT, and paracetamol, and diclofenac. So nitrates have no role here. Correct?
Diclofenac.
Diclofenac is the drug of choice. Okay, even if you have any other drugs, diclo is the drug of choice. Okay,
Okay.
pethidine is a type of what you call opioids, but it's not indicated in this. Okay, the answer is diclo. Which of the following stones are hard to break by ESWL? See, I'll tell you about ESWL. It stands for extracorporeal shockwave lithotripsy. You're going to give shockwaves from the outside, okay, outside the body. These waves, what happens is they're going to pass to the soft tissue, and then once they encounter a hard substance like a stone, the energy will be transmitted to the stone, and then it's going to cause breaking of the stone, erosion and shattering of the stones. Okay, that is called ESWL. That means you are going to break the stone basically in this procedure. So now, which is the stone which is hard to break? Calcium oxalate monohydrate or dihydrate, uric acid or steroid?
It's a cysteine stone.
It's the calcium oxalate monohydrate among the given options. Cysteine is the hardest. I totally agree. But among the given options, calcium oxalate monohydrate happens to be the hardest one compared to the dihydrate or uric acid or steroid. Cysteine is no wonder the hardest stone, but after that comes the calcium oxalate. That is monohydrate. Okay.
Okay.
All are radio opaque except. So use your mnemonic here, which is radiolucent.
Uric acid.
Uric acid.
That's good. Randall plaques will cause. We've discussed about this. They cause
Urinary stone.
Urinary.
right. So they're not pre-malignant. Okay. Somewhere people will like plaques will be the pre-malignant condition like your leukoplakia and those things. These are just to do with stones. Okay. These were some of the questions. This happened to be just anatomy class. There are not many questions on this. So further on, we'll talk about the management of renal stones, and then we'll talk about bladder and prostate and so on. Okay, we'll take that in our next classes, subsequent classes. Okay.
Yes, ma'am.
Okay. Hope you like the class. Thank you for attending the class.
Thank you, ma'am.